Oh, that was great. Now, our next speaker will be Don Ponec from American Access Center in San Diego, and he will share with us his perspectives on the treatment procedure.
Well, thanks for being here after a Saturday night in New York. And this is kind of a nuts and bolts talk. It's something that interventional radiologists really enjoy. There will be no equations. There's a lot of experience in the room, interventional radiologists with cumulative experience here, probably of 100,000, 200,000 angioplasties, and that's primarily what we're talking about. And so, you know, we know that this procedure centers on that. There are always going to be nuances that surround how we're applying angioplasty in a new vascular bed or in a different application. But for the most part, there'll be some general guiding principles that we use every day in our practice everywhere else. I have no disclosures, unfortunately, and let's just move on. So we've already reviewed the history of CCSVI. Rindelfleisch in tone back in 1863. This was a venous congestion process, and we know what's been going on since then. A lot of interest. And this is really exciting for interventionalists because we like, you know, this is sort of the heady days for us when sort of like when angioplasty first started, or TIPS, or any of the other procedures that are early on, and we're learning about what's influencing our outcomes and new techniques that might drive this, whether it's stents, IVUS, cutting balloon, all these different things that, that may or may not prove to be useful. We know in detail about the pathophysiology or proposed model for that, that there's some impact of venous reflux or congestion on the development of MS plaques or progression of the disease, or maybe just development of symptoms that are layered on top in MS and other diseases. So we're still obviously learning about that. And the venous anatomy of the head and neck we're hearing a lot about, and how we're going to evaluate that, and whether certain types of abnormalities really are abnormalities, or if they're just normal physiology. And of course, it's hard for our colleagues in other aspects of medicine to even understand how this would have an impact, because I mean, early on we treated a lot of baseball players with Paget-Schroeder syndrome. They had subclavian vein occlusions from hyperactivity, and one of the main operations that was useful, at least the pro athletes would get, was a jugular turn down. You'd ligate the jugular vein on one side, turn it down, and attach it to the subclavian vein. And so the theory always was there's so much venous capacity, then there really should be no problem with venous obstruction of the jugular vein. And so I think there's a lot of background for why colleagues in other areas are wondering about this. Why are we saying that a jugular vein stenosis can create these problems? And yet there are models elsewhere in the vascular bed and peripheral vasculature. You know very well that if there's reflux in the lower extremity veins, you get inflammatory changes and abnormalities. And when that reflux is removed, either through, in that case, a saphenous vein ligation, those changes go away very nicely. So, I mean, there's somewhere in between, perhaps, and that's what we're learning. So we screen for this, this new concept of CCSVI with MR, MRV, functional MR, ultrasound, using the Zamboni protocol or other protocols. And we use for our treatment indications multiple sclerosis, the presence of that, hemodynamically significant venous stenosis or flow abnormalities. And the question mark really is other neurologic diseases, and that kind of gets to what's the relationship between CCSVI and MS, or is it an overlay that affects other areas? So there's some basic concepts, of course. First is safety. The validation of CCSVI as a factor is as much as we've all experienced the clinical results and the outcomes and changes at functional MRI and other things. The proof's still pending, so we have to kind of bear that in mind and use the old adage of first do no harm. Protect the patient and stay out of harm's way. It's to us, it's our obligation to try and standardize as much as we can our techniques so that we can compare our data from here across the country and around the world. You know, what is our target outcome? Is it angiographic? Is it structural? Is it clinical? And what's the optimal appearance after treatment? And how do we follow patients? And there are a number of questions, and we're kind of now at that midpoint of a new process to sort of agreeing and starting to agree on what that's going to look like. Lesion types, Dr. Scalfani has talked about stuck valves and other types of webs, and whether those are parts of the vein or if they're fibrin sheaths or if they're old clot, or, you know, we're still looking at all of that sort of stuff. Extrinsic compressions, do you treat them, do you not, do you operate on these? Azygous arch, how do you assess that? And then what's the role of other veins, pelvic veins, renal veins? They all have different characteristics and potentials for treatment. And again, we're sort of still in that definitional phase of what we're actually, what's our target? You know, what are we looking for in the end after we're finished with our treatment? Options, lots of them, which is good and bad. Lots of things to think about and options to offer patients. PTA is still really the mainstay, balloon angioplasty. High pressure balloons, larger balloons, does that make a difference? Probably yes and no in that case. Primary stent placement, does that ever make sense? Stent for technically poor outcomes only. What's the role of cutting balloons, atherectomy devices, cryoplasty, people are talking about. And so, you know, just to kind of categorize the types of lesions in a very simplistic form, you know, there's three areas that, you know, mainly looking at in the jugular, lower, here on the left, which is the valve site stenosis, and that's where about 2/3 of the lesions are. Mid, where you kind of see a lot of compression things that are head position related and other areas, and whether you treat that or not is a question, but in our practice probably not. And then the upper jugular stenoses or occlusions. Balloon angioplasty is really the only thing that's been studied to any great degree. No major complications, thank you, in our practice so far. And this is dates back to the original treatment, which was by Dr. Zamboni, in which he used angioplasty in 65 patients. Had a good outcome, clinically significant or statistically significant clinically based outcome. Restenosis was high, balloons were small, and so, you know, again, early on we're still defining techniques. So, you know, what the best technique for CCSVI is going to be, we're still thinking, but you know, some basic angioplasty guidelines are going to apply here as anywhere. Restenosis, of course, is a problem. Up to 50% of patients are going to experience this. It occurs everywhere. It's nothing unique about the jugular venous system. Anywhere we do an angioplasty, there's this potential, fibrous scarring or re-narrowing of a vessel that occurs 1 month to 2 years. But usually there's an early phase when it's most likely, especially in the arterial side. Mechanism seems to be related to vascular injury and a response to the injury leading to a restenosis. It's not an equation, it's more of a graph, so sorry about that. But Lindsay McCann is an expert in this, and many others sitting in this room. But we realize there are inflammatory mediators that can lead to proliferation and migration of smooth muscle cells and deposition of an extracellular matrix that can re-narrow an angioplasty site or a stent even more. There have been a lot of techniques used elsewhere in the vasculature that have been promoted on an investigational basis. Cryoplasty, atherectomy, high pressure balloons to overcome lesions. Many of them really shown no actual benefit in the end analysis. Cutting balloons are promoted as maybe a way of doing this. You know, I think for us, we kind of look at the optimal outcome venographically, and so whatever gets us to that point is how we operate. There's no single answer. Most patients start with an angioplasty, but if we need a cutting balloon to get the optimal result, I'll show you a case of that in a minute. You know, we do it, but I don't know. We'll maybe in the session talk about whether this is something people are doing every time. Cutting balloons are a little bit limited based on size, but that's just a matter of the companies catching up and making bigger balloons that are cutting balloons. So again, at least in the other vascular beds, cutting balloons really haven't, just when applied across the board, shown any statistically significant benefit over just other techniques. Again, a little bit limited in CCSVI. Here's a case where we're dilating a left jugular vein, very tight stenosis. We're up very high pressure on that left-hand panel there, and not really able to get a full diameter balloon dilation. And again, that lumen is already bigger than any cutting balloon on the market. So what we do is we put up a parallel cutting balloon in this case. You can sometimes people are putting a guide wire along it, thinking that'll maybe channel an angioplasty along the length of the guide wire. But in this case, we used a cutting balloon, then redilated and got the result on the right, which was, a very nice way of solving the problem. We've, out of 350 cases, this is maybe 3. Again, it's a niche problem-solving thing for us. A lot of hyperbole out there, again, as this has become a little bit more of a commercial venture, there's people claiming superiority of one technique over another. Really don't have any data to support any of that at this point. So you have to be a little bit cautious about that sort of thing. And then the other big question is stents. A lot of different attitudes about that for maintaining jugular patency. There's some downsides, obviously. Well, a lot of downsides. First, requires anticoagulation for an extended period of time. There's a restenosis and occlusion rate for stents. There have been reported cases of migration. Nerve palsy is associated with stents at the skull base from the spinal accessory nerve with muscular paralysis. And we had one case of that in a stent patient that recovered spontaneously after 2 to 3 months. And they're not retrievable. That's the thing, is that there are a lot of there's a good argument that if you're going to be doing angioplasty and you're having to come back, given the current stents, really the stents are really maybe not ideal for this application at this point, and so we've encouraged people away from that. We have put stents in certain locations. Here was an early patient had a extrinsic compression, we thought, that led to an intrinsic lesion of the vein. Hard to know exactly if that was true, but it certainly, no matter what we did with a balloon angioplasty, nothing would improve this. This was the only lesion. It was an isolated lesion. The vessel was essentially occluded, so we did put a stent in that, and the patient had a nice recovery, and that's been a durable response. On the other hand, here's another patient with an occluded stent, and that does happen too. We've had 2 patients now, I think, come back with occluded stents, and that is a very disappointing thing for everybody. Here's another patient on the other side who had an occlusion that we stented early on, and this has been durable now out to a year. And so it's hard to predict just based on the venogram. There's probably patient characteristics that we have to investigate that are going to drive stent patency. But at least in our practice, it's a problem-solving tool and a niche device. For an isolated occlusion that doesn't respond to an angioplasty and everything else looks normal, we consider stent, and that's really about the only time currently. And of course, this is the problem. You get this exuberant intimal hyperplastic response inside of a stent. It's a complex structure, and so a lot going on in that vascular segment. This is courtesy of Lindsay McCann, and there are a myriad of techniques without clear evidence for treatment in the legs and in the past, and we know that angioplasty worked well. And just kind of looking at the legs as a model, we knew that there was a restenosis rate in the legs, and so when we started doing stents in the legs, there was a question of whether different types of stents or drug-eluting stents might be helpful. And what we found is that the superficial femoral artery, which was always sort of a really it seemed like a very straightforward thing. It's easy to work on for the most part. Turned out to be an incredibly difficult vessel, much more complicated than most people would have thought. There's a lot of motion, flexing, bending, compression, longitudinal motion of that vessel, which makes it the range of motion in the lower extremity makes it extremely difficult. And the neck, when you think about it, the jugular venous, even though it's a completely different vessel, it's a vein, not an artery, it's going to have similar stresses, similar issues. Just to kind of compare, here's an SFA lesion that was stented. That's a particularly difficult area, a lot of motion. And we know that, for example, by adding certain drugs, in this case paclitaxel, to a stent, we see a 50% reduction in restenosis. So then that leads, the next question is, well, are we going to be looking at drug-eluting stents? This is a very different vascular bed. The drug elution rates and drugs that we're using in the peripheral arterial system actually have been tried in the veins with no impact. And so if drug-eluting stents are going to be an answer down the road, it's really yet to be defined. We know that stents have been used extensively for dialysis and DVT-associated stenosis, but those are really not the exact same thing as this. I mean, when you think about a dialysis circuit, as we saw earlier, that's really an arterialized segment. That's really not a normal vein at that point. This vessel's been subjected to arterial flow, and the wall of the vein itself is changing. So that remains a pretty confusing area. And again, when I talked to Lindsay the other day, he said, you know, essentially everybody and his dog's working on a venous stent right now, and what that's going to mean is it going to be what are the physical characteristics, the radial force, hoop strength, is it absorbable, is it drug-eluting? A million questions to answer there, but there may be some answers down the road. Safety, we know from Dr. Mandato's presentation at SIR that there's a good safety profile for this. And the same in our hands, I would say. But it's still a procedure. There is still risk associated with this. We know very well that there have been some major complications. And in some cases at some very experienced centers, including some deaths from intracranial hemorrhage. But the reporting of that's sporadic, and again, this is an area where we need to kind of clarify how we're reporting our outcomes and make sure that we know what's going on throughout the United States and around the world. So bad things can happen. We want to minimize our complications and maximize patency. Our technique, diagnostic venogram, always to the transverse sinus. First, it confirms that you're actually in the jugular vein in some cases, and it tells you what the dynamics of that is. We oversize the balloon 10 to 15%. Look at the head position. It's not always 100% which way will relieve an obstruction, but we always look in different projections and head positions. We'll increase the pressure in the balloon to a point where a moderate amount of discomfort may be experienced. We're not trying to rupture the vein, but actually patient response seems to be a reasonable guide in terms of the amount of balloon dilation. We use other techniques when necessary and stents when other techniques fail. This is just some quick examples. Here's a lower jugular vein where lesion where the valve was visible and narrowed. There was reflux up higher, just a balloon angioplasty, and you see the result on the right. This is sort of your basic picture of CCSVI treatment. Here's an upper jugular lesion, same sort of thing. A lot of collaterals initially, balloon angioplasty and improvement. Azygos vein, we're going to talk about this a lot more, I think, because the azygos vein, how we approach this is a little bit different. You see a little cartoon on the left showing the anatomy, and how you study this is interesting. Lesions seem to fall into two categories, either in the arch or in the ascending portion, you know, the vertical portion of the azygos vein, which is prone to compression. You know, we're doing patients' evaluations in a supine position, so there's compression. I think we do them in deep inspiration, as others here have alluded to try to eliminate that. But we know very well from prone MRVs that a lot of times that's a completely dynamic and probably not significant lesion. As far as the azygos arch, when we see valves like this, we're dilating them. We don't rely on any other technique. And, you know, IVUS and these things I think are interesting from an academic point of view to sort of see what this looks like. In our experience, that hasn't driven therapy. In the end, you know, Yogi Berra says, when you get to the fork in the road, take it, right? I mean, you have to decide at a certain point, are you going to dilate it or not? And that's really your only options. And so if we don't find you know, in our practice at least, IVUS doesn't help us with that because that decision-making process is either a yes or no, and in this it's yes. This is an example of that extrinsic compression, that lower left panel that shows what we used to call candy wrapper or twist in the azygos vein. Of course, embryologically, the azygos vein can't be twisted, right? I mean, you can't take the mediastinum out, spin it around, and put it back in. That just doesn't happen. That's an extrinsic compression, and we know that very well. We still dilate it to see what happens, but it almost never really changes. And then May-Thurner syndrome was alluded to earlier. We've treated one patient out of 350. So I mean, it's a, whatever that is, a 0.3% rate. Pretty uncommon, but this is what it is. The right common iliac artery crosses over and compresses the left common iliac vein at the sacral promontory and can cause some intimal bridging that leads to a stenosis or occlusion, and those are usually treated by stent. Well, they're always treated by stent. So in conclusion, the treatment of CCSVI is not simple, and best practices are not yet clearly defined, although I think we're really maturing in this area. We're really striving toward this. We talked about it last night at dinner with many of the experts that are here, and how we're going to start to survey how people are treating the disease. We were joking that it's nice to have that survey so that, because interventionalists are sure that they're doing it right, so it's just nice to know how far off all of our colleagues are, is sort of was the approach at dinner. But you know, that's really just tongue-in-cheek. Really, I think there is going to be a coming together of a certain treatment branched diagram as to how we're going to do this most effectively. That'll be data-driven and based on evidence that hopefully we're going to be getting. And again, I guess the plea is safe treatment. You know, beware of claims of better, because we really haven't even defined better yet. We don't know what that is. If it's better, it means venographic. If it's clinical, if it's fMRI, or what it is. But we're getting a lot closer to knowing what better is. Thank you very much.